really excited to have one of our own staff members, Alex, on the e-course. So a little bit first about A&PI Wellness Center. So we're a health services, education, research, training, and policy organization with over 25 years of experience that provides culturally and linguistically competent services to communities of color and LGBT individuals. So you can always look for more information on our website about apiwellness.org, and feel free to check that out. Our mission is to transform lives by advancing health, wellness, and equality for people of all races, ethnicities, sexual orientation, gender identities, and immigration statuses. So now a little bit about our CEBA program. Our capacity building program specializes in a couple of main areas. The first one is HIV testing. So we do technical assistance or trainings around targeted recruitment, quality assurance, linkage to care, HIV treatment, so the biology of HIV, ART, and medication adherence, prevention of people living with HIV, so these are our HIP interventions such as CLEAR, PROMISE, CHTC, patient navigation, and partner services. We also do condom distribution as a structural level intervention, so talking about needs assessment, campaign design, social media, and evaluation. And lastly, we do public benefits. So this is part of our California-specific program, C-STEP, which is about Social Security, disability income, healthcare coverage, Ryan White programs for people living with HIV/AIDS. So if you have any questions during the webinar about our CEBA, how we can help you get connected to this webinar in general, feel free to send us an email or just message us throughout the platform. So we're really excited to welcome Alex to our webinar, and he'll be talking about cultivating cultural humility and considering cultural factors in advancing the quality of care. So welcome, Alex.
Thank you, Melissa. I want to thank you for introducing me. I also want to thank Melissa as well, because this is actually a condensed and modified version of a training that Melissa had developed for our clinic staff here at A&PI Wellness Center that we trained them back in November. So thanks, Melissa, for putting that together. We've modified it a little bit to fit more in line with the goals of the e-course, so hopefully you'll find it to be helpful and effective. So why don't we begin? So the title of this webinar is called Cultivating Cultural Humility, right? And we want to make sure that you guys understand as service providers how culture, stigma, and discrimination are going to affect health outcomes. And we want you to gain this really strong understanding of cultural humility, how to practice it, and its role in providing quality care and service. And hopefully this will increase your capacity to create environments to make clients feel supported and comfortable when they're engaging with healthcare providers and service providers. So let's take a look at our definition of culture. This definition was defined by CATS and the National Standard for Culturally and Linguistically Appropriate Services in Healthcare Settings. So I'm just going to read this for you all. Culture is the thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. Culture defines how healthcare information is received, how rights and protections are exercised, what's considered to be a health problem, how symptoms and concerns about the problem are expressed, who should provide treatment for the problem, and what type of treatment should be given. And the key takeaway is that culture is multifaceted. You'll see different aspects of cultural identity, and we're going to take a look at a list of those right now. So here we have a list of different cultural considerations. You'll notice that this list is not exhaustive, but there are several different aspects of cultural identity that we have to take into account when we're working with our clients or our patients. And like I said, this is a non-exhaustive list, so if you can think of any other variables that are related to culture, please type them in the chat box, and we'll talk about them later on when we do our Q&A and discussion. So culture is something that's not homogeneous, it's something that's not static, it's multifaceted. And when we think of culture, we have to think of it as this Venn diagram where we're living in that part of the Venn diagram in the middle. With all those components interacting with each other, right? And that includes our behaviors, our attitudes, and our knowledge. So our behaviors are our actions, our attitudes are our values and beliefs or judgments about something, and our knowledge are our thoughts and awareness. And it's not that one single variable, but multiple variables that affect all aspects of our lived experience. And it's really important to remember that cultural processes are frequently different, even within the same ethnic or social group, because of differences in age, differences in social network, gender, differences in political association, differences in class and religion, ethnicity, and sometimes even just individual personality traits. So let's take a look at our treatment cascade, and I'm sure you've all seen this before if you've been working in the field, because we've been talking about it for the past 6 years now, over and over. So I'm not going to explain the cascade to you because our course that we have does a pretty good job of that. But I do want you to think about the different steps in the cascade and how culture can affect those health outcomes. So let's take a look at some examples of how culture can affect those health outcomes. So here on the left, we have our treatment cascade that with our national sort of averages of each step during the stages of from diagnosis to viral suppression. And on the right, we have a version of the cascade that shows the differences in health outcomes based on race. So the data that we're using for this compares the outcomes of white, Black, and Latino persons living with HIV/AIDS. So as you can see, the white persons in the US living with HIV/AIDS have much better health outcomes at each stage in the cascade. And you'll see smaller percentages at each stage with Hispanic or Latino populations, and even smaller percentages with Black populations living with HIV and AIDS. Our next graph comparison shows the national averages as compared by, or broken down by race, right? Or excuse me, age. So here we see percentages increasing at almost every stage as age advances, but then dropping back down for those 65 and over. And finally, our last example, just want to show you, we have our graph on the left that compares our outcomes to, and our graph on the right that compares our outcomes to those in Denmark and France. And we can see that the rate of viral suppression in both of those countries as compared to the US is almost doubled or more than doubled. So the bottom line here, the message that we want you to get out of this is that culture certainly does affect health outcomes, and it can do so in a variety of different ways, right? You won't really know everything about a person's culture when they come in to see you. It might not always be appropriate to ask, and you should absolutely never make any assumptions about someone's culture or how it affects their health. But what you can do is create this supportive and comfortable environment that facilitates the sort of open and honest conversations that you can have with your clients about their health concerns. And how we do that? Well, we do that by practicing cultural humility. So when we think about our clients, we really have to think about this long and complicated history that they might have with the medical industrial complex. And this extends beyond just individual interactions with healthcare professionals. The roots of the medical industrial complex run very deep, and its history is connected to all different systems and forms of oppression. So you have to think about this long and complicated history when we're delivering care to our clients and patients. We can sometimes see barriers to care that are structural, right? They're interpersonal, they're structural, and they can really impact people's access to healthcare. And this is why it's so important to make sure that your clients and patients feel comfortable with their service and care providers and believe that these professionals in their community are knowledgeable about how different aspects of their culture could affect them. And here we have a few examples. So someone of a low socioeconomic status might not have the resources to pay out-of-pocket healthcare costs that they might incur as a result of their visits. Or they might have trouble accessing transportation to get to their doctor's appointments and other providers, right? Someone who identifies as transgender might have this history of providers refusing to call them by their preferred name or gender pronoun. Someone might be a part of a race where people have a history of being used for medical experiments. Or they might be from a country that prefers homeopathic remedies and doesn't really rely on pharmaceuticals. We have to keep all of those things in mind, right? Someone might be living in a food desert, or they might be living in a fast food swamp, and they're not getting access to proper nutrition. So I have a little story about this. We did, back in September, we facilitated a training in Birmingham, Alabama, and we were staying in this neighborhood that was very much like a fast food swamp, right? So I try to stay active when I travel, which is tough. I went to visit the hotel gym, but I felt like I needed some protein so I could have the energy to work out. And I went to a few stores around the hotel. There was no protein to be found, no fruit to be found. All that I saw at these stores were 40 ounces, chips, things that are really not gonna get you the proper nutrition that you need, right? And don't get me wrong, I love a 40 ounce of Colt 45 just as much as the next guy. However, if you're trying to care for yourself and take care of yourself and put things in your body that are gonna, be nutritious for you, it's gonna be really difficult to do so if you don't have access to ingredients or fresh foods that's gonna help keep you healthy, right? So just an example of another one of those barriers. So now let's take a look at our definition of cultural competency, because this is a buzzword that we hear across a variety of different fields. It's really obvious that culture matters in clinical settings, and cultural factors are really important to diagnosis, treatment, and care as they shape health-related beliefs, behaviors, and values. So according to the US Department of Health and Human Services, cultural competency is this process of learning that leads to an ability to effectively respond to the challenges and opportunities posed by the presence of cultural diversity in a defined social system. And this term itself can be a little bit problematic. We're now going to take a look at why. So the problem with the term cultural competency is that it kind of insinuates that culture can be reduced to this really technical skill that clinicians or service providers can be trained in and develop this expertise. And the definition of culture in medicine is really different than the way it's defined in anthropology, right? In medicine, when people think of culture, they think of it as synonymous with ethnicity, language, or a person's nationality or country of origin. So by this definition, clients of a certain combination of those traits are assumed to have this core set of beliefs about illness owing to those fixed ethnic traits. And cultural competency then becomes this sort of finite list of do's and don'ts that define how to treat a patient of a given background. And this can be kind of isolating due to shared cultural meetings, according to anthropologists, can lead to some dangerous stereotyping, right? If we're thinking of it in this way, we can be generalizing people and we can be attributing all of their behaviors to their culture, and that can cause issues, right? Because then we're not looking at the individual, and then we're losing our client-centeredness. Another issue that some people raise is that sometimes cultural factors, they're not always central to the case, and they might actually hinder a more practical understanding of the episode. So we like to use the term cultural humility, and that is the ability to maintain an interpersonal stance that's other-oriented or open to the other in relation to aspects of cultural identity that are most important to the person. It focuses on self-humility as opposed to achieving this sort of set state of knowledge or awareness. So J.N. Hooks came up with this definition, and J.N. Hooks was a psychologist that conducted research on multicultural orientation. And according to Hooks, cultural humility just really involves being open-minded and understanding of the aspects of someone else's culture and how it can affect their life. So when we think about cultural humility, we have three different components. The first of those is this lifelong commitment to self-evaluation and self-critique. We have to keep in mind that we're never really finished in terms of our learning about culture. We have to be aware of how our own cultural identities affect how we interact with others. We have to be humble and we have to be flexible when we're going forward. And when we don't know something, we need to be able to admit that, right? Not just sort of justify it. We need to be open to understanding different things. The second component involves fixing power imbalances. So healthcare professionals and service providers are often believed to hold the power in their interactions with clients or patients. And this desire to fix power imbalance is based on the idea that when we work with clients, the client is really going to be the expert of their own life. They're going to be the expert of their own symptoms, their own strengths, while the practitioner or the service provider, we're the ones that hold the knowledge of medical systems and service systems, right? So both parties have to really collaborate and learn from each other in order to have the best health outcome. And our third component involves developing partnerships with people and groups who advocate for each other. As individuals, we sort of need to advocate for our systems and organizations to do some self-critique and fix those power imbalances just like we do for ourselves, right? So it's not enough that we're individually trying to fix these power imbalances or our own interactions, but we need to try to work with other providers to influence them, to motivate them to try to do the same thing. So I want you to think about these three components of cultural humility as we move forward throughout this webinar and in your work. So the concept of cultural humility goes kind of hand in hand with patient-centered care or client-centered care. And this is essentially meeting clients where they're at. You know that you want your clients to be able to direct how they're cared for. We as providers, we might have goals or agendas for our clients, but those goals need to be harmonized with the goals of the clients themselves in order to optimize their care. And this model for patient-centered care was formally theorized back in 1986 by the Picker Commonwealth Program to increase the focus on patients' needs and concerns. And in this formal model, there are 7 dimensions of patient-centered care. So the first dimension involves respect for the patient's values, preferences, and expressed needs. The second involves coordination and integration of care. The third involves information, communication, and education. The fourth involves a patient's physical comfort. The fifth, emotional support and alleviation of fear and anxiety. The sixth, the involvement of friends and family, right? Because if you have people involved in your care and supporting you to take care of yourself, you're going to have better health outcomes. And finally, transition and continuity, making sure that people can maintain these behaviors that are healthier for them. And this diagram shows how all 7 of these key features can come together within interpersonal interactions between patients and providers. So when we think about patient-centered care, it's really important to think about the interpersonal communication messages of cultural humility. And this involves the ability of the provider to bridge cultural differences and build this effective relationship with the patient. So for example, you want to explore and respect the patient's beliefs, their values, what their illness means to them, their preferences, and their needs, right? And doing so is going to build rapport and trust. This helps you find common ground. You also, when you're communicating with your patients and clients, you've got to be aware of your own biases and assumptions about people based on the different aspects of their cultural identities. You want to be knowledgeable about these different aspects of people's cultural identities, and you'll want to be aware of how the aspects of their cultural identity affects their health outcomes, and you want to be aware of different health disparities and discrimination that affects oppressed groups. And if you have a situation where you have a language barrier or something, you want to effectively use interpreter services when you need to. So when we think about patient-centeredness or client-centeredness and cultural competency in our interpersonal interactions in healthcare, the real benefit is going to be thinking about them in combination. So at the core of both client-centeredness and cultural competence is this ability of the healthcare provider to see the patient as this unique person, right? To maintain this unconditional positive regard and to build this effective rapport, to use that biopsychosocial model to explore patient beliefs, their values, the meaning of their illness, and to find some common ground regarding treatment plans, something that works for both the patient and the provider. And this patient-centeredness model actually includes a detailed set of knowledge and skills that the healthcare provider should possess in order for them to accomplish these tasks, like understanding the stages and functions of a medical interview and attending to the patient's physical comfort. Such details usually not explicit in accounts of cultural competence. Most of these characteristics of client-centeredness might be endorsed as traits of a culturally competent provider. So now let's talk about the different kinds of experiences that people might be subjected to based on different aspects of their identity. So first, I'm going to go over some key terms that you might be a little bit familiar with. And the first of those is prejudice, right? What is prejudice? Well, prejudice is an attitude. It's a judgment of an individual or a group. And if we break the term down, we see the word pre and then the J-U-D, judge, right? We're prejudging somebody. We're making a decision about someone before just based on one aspect of their identity, before we even know anything about them. Now, prejudice, although it's usually harmful, doesn't necessarily have to have a negative connotation behind it, and that's where stigma comes in. So stigma involves a little bit of prejudice in that you are prejudging people, but stigma refers to those unfavorable attitudes and beliefs that are directed towards somebody or something, right? And then we have discrimination. So discrimination is the unfair treatment of an individual or a group based on those particular aspects of their cultural identity. And this is usually defined in terms of human rights and entitlements in various different spheres, including healthcare, employment, the legal system, social welfare, and reproductive and family life. So stigma and discrimination are very closely linked. how to tell the difference is stigma reflects the attitude and discrimination is the behavior based on that. So there are a few different types of stigma, and they're both very important to understand. So the first is felt stigma, and this is also known as internal stigma or self-stigma. And this is the shame and expectation of discrimination that kind of prevents people from talking about their experience and stops them from seeking help. Then we have enacted stigma or external stigma. And this refers to the actual experience of unfair treatment or discrimination by others. And it's important to remember that felt stigma can be just as damaging as enacted stigma because it leads to withdrawal and the restriction of social support. And when we're thinking about cultural humility, it's really important to think about the compound effects of stigma, right? That many of our clients have in their intersectional identities in multiple groups that may be socially marginalized. So we'll talk a little bit more about intersectionality later on in the webinar if you're not familiar with it, but it really just involved the different aspects of a person's identity, different identity aspects that might be oppressed and how they interact with each other. And all these terms are really important because they have this profound effect on both the physical and mental well-being of our clients. They affect service delivery, they affect access to services and more. So now we're going to take some time to talk about some of the effects of stigma and discrimination and their connection with stress. So for this, we like to use the minority stress model. And there are three main principles of the minority stress model. And the first is that minority status leads to increased exposure to distal stressors. So distal stressors are external processes, right? Things like experiences with rejection, prejudice, and discrimination. The second principle is that minority status leads to increased exposure to proximal stressors because of distal stressors. So basically, you're being met with all this discrimination all the time. People are treating you differently. You're then going to expect it. You're going to be on guard about it. You're going to develop some anxiety about it. And that's what proximal stressors involve, the expectation of these distal stressors. And they include things like the concealment of one's minority identity, hypervigilance and anxiety about prejudice, and negative feelings about their own group. So they're starting to then internalize those negative feelings. And minority individuals suffer adverse health outcomes, which can be caused by exposure to all of these stressors. So we know that HIV is a virus that's stigmatized, right? And that living with HIV can subject someone to prejudice and discrimination. And that includes the principles associated with the minority stress model. So let's take a look at HIV and AIDS related stigma. So this kind of refers to all the unfavorable attitudes and beliefs directed towards a person living with HIV or AIDS, or those perceived to be living with HIV and AIDS, and towards their significant others, their loved ones, the people that they're closely associated with, their social groups, and the communities that they're a part of. Stigmatizing attitudes are usually directed not only towards the person living with HIV, but also towards the behaviors believed to have caused the infection. And stigma is really pronounced when the behavior linked to the origin of a particular disease is perceived to be under the individual's control, like sex work or injection drug use. When we think about, people and their stigma and discrimination concerning HIV and those behaviors, and the people engaging those behaviors are thought to be irresponsible, right? Or that they made bad decisions. When in reality, a lot of the people that are inflicting this discrimination on them engage in the same exact behaviors that the individuals living with HIV do. They just weren't exposed to the virus, so they have not been infected. So HIV and AIDS-related stigma is really complex and dynamic, and it can show up in healthcare settings in a variety of different ways. So I'm just going to go through a few examples of how that can happen. Sometimes doctors will refuse to provide care, treatment, or support to a person living with HIV or AIDS, or the care that they do provide or the service that they do provide is of a really poor quality. Sometimes doctors' offices might violate confidentiality. Some individuals can only receive care at clinics specific to HIV and STIs, which can further stigmatize them and segregate them from other general medical populations, right? There's doctors that do things like use gloves or wear masks only when they're working with patients who are living with HIV rather than with everyone. And some doctors might advise persons living with HIV to undergo procedures like abortion or sterilization, that they wouldn't ordinarily suggest for someone who's not living with HIV. So all of these things can really mess with someone and lead to really poor health outcomes and cause their stress levels to go up. So these are some more conscious or blatant forms of discrimination, but there are other stigmatizing behaviors that kind of fly under the radar. And those are what we call microaggressions. So I'm going to read you guys a definition of a microaggression. And this was a term coined by a psychiatrist named Chester M. Pierce in the 70s. And Chester M. Pierce used this to describe insults and dismissals that he said he regularly witnessed non-Black Americans inflict on Black Americans. So since then, the term's been extended to include similar aggressions towards any socially marginalized group. And although microaggressions are micro because they often happen in small, private situations, they can often have this significant and dangerous impact. They're usually unconscious and they're usually unintentional. So perpetrators of these microaggressions might not realize the negative impact that the messages have on members of oppressed groups. And this makes them a lot harder to identify than overt racism. It's more difficult to confront or address, or both, because victims of microaggressions might have different perceptions and racial realities than those who enact them. So just to go over this definition, these are brief, commonplace, daily verbal, behavioral, or environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative racial sites and insults toward people of color. So since they're so unconscious, it's really important to think about them when we're trying to understand cultural humility. We might not be realizing the harmful ways that even we cause microaggressions to our clients or our patients, or even the many microaggressions that they might have experienced by other healthcare providers before you've even met them. They have this really significant effect on the physical and mental health, as well as the desire to interact or engage with healthcare and supportive systems. So there are three different types of microaggressions that we're going to go over. And this psychologist named Dr. Gerald Wing Su theorized this. And I just want to iterate that although these terms are originally related to anti-Black racism, they apply to lots of different aspects of one's cultural identity, including persons living with HIV. So the first are microassaults, and these are the most common and intentional form of microaggressions. They resemble what we think of as old-fashioned racism. The second are micro-insults. These are communications that convey rudeness and insensitivity, and they demean a person's racial heritage or identity. They're subtle snubs, they're unknown to the perpetrator, they have hidden insulting messages to the recipient, right? And our third type of microaggression are micro-invalidations. So these are communications that exclude, negate, or nullify the psychological thoughts, feelings, or experience or reality of a person belonging to a particular group. So now I'm going to make this a little bit interactive and do a little quiz with you all. So feel free to type your answers in the chat box. So first we have our first question. We have an example of a microaggression. We want you to tell us whether it's a micro-invalidation, a micro-assault, or a micro-insult. So telling an individual living with HIV that they need to lighten up about HIV/AIDS-related humor. Please type your answers in the chat box if you feel like you know the answer. So we encounter this a lot, right? When we're with people who may not be so knowledgeable about HIV or so close to people living with HIV, people tend to make a lot of jokes, right? And that's something that's not okay with us as service providers, but it's kind of accepted among general populations who are not so closely connected. And you know, it can often happen that if someone feels comfortable enough to even speak up about the joke, that someone might tell them that they have to lighten up, oh, it's just a joke, which is very unfair. So give you a few more minutes to come up with some responses for that. So we do have a response that this is a micro-invalidation, which is correct. That is an example of a micro-invalidation. So we'll move on to our next example. So question number 2, what type of microaggression is this? A patient or client voicing concerns about a recent ongoing health problem and the provider responding with, well, you have HIV, right? So please, if you know the answer to this, type it in the chat box. In this scenario, an individual living with HIV goes to see their provider. They want to talk about something that they've been having issues with, and their provider just chalks it up to, well, you have HIV, so obviously you're going to have these chronic health problems. Too bad, so sad. You know, they're not really having any compassion or empathy for their client. What type of microaggression do you feel like that is? I'm going to give you guys another minute to bring in some responses. You can guess. If you're wrong, it's okay. These can be kind of complicated, and also not every single kind of microaggression is going to fit into one of these categories. This one does, though. So it looks like we do have a response that this is a micro insult, and that is correct. This is a micro insult. So great job for whoever submitted that answer. And then our third and final example, what type of microaggression is this? Big hint, there's only 3, so by process of elimination, you probably got it, but we're gonna go over this example anyhow. So claiming that someone acquired HIV because of their irresponsible behavior, what kind of microaggression is this? And we should be getting this answer like rapid fire from you guys, right? And we talked about this a little before, that often people are judged for their behavior or behaviors that led them to acquire HIV, which is extremely unfair because we know, again, that lots of people engage in those same behaviors without acquiring HIV just because they're not exposed to it. So it doesn't look like we've gotten any responses yet. So I'm going to continue on and reveal the answer. And this is an example of a micro assault. So I want to thank everyone who participated and answered these questions. So Brian, Dylan, Radhika, Alexander, and Santos, thank you all for your responses to these questions. We really try to make these as interactive as we can, which is really difficult when we're presenting remotely. But I want to thank you guys for participating in that. So now we're going to move on to some health consequences of HIV and age-related stigma. So as you can see, there are lots of different consequences of HIV and age-related stigma that we see affecting our clients and patients. And the first one is that persons living with HIV might be afraid to access prevention services because they feel like providers are going to judge them for engaging in sexual behaviors. And this is something that I can kind of attest to based on my own experience working in direct service. So most of my work involved prevention with those who are HIV negative, but a time came when we started trying to integrate some of the services in our client services department with the services in our prevention services department. Which would lead us to have conversations with HIV positive clients about sexual health, STI testing, and things like that. And wouldn't you know that everybody had the same story, which was, I'm not currently sexually active, right? Now, I predominantly worked with men who have sex with men, and we would do a lot of online outreach. And during this online outreach, we would see these same individuals that would tell us that they weren't having sex with their profiles and photos on all these websites and apps with as little clothing as possible, as little clothing as a platform would allow, sometimes no clothing at all, and they would be describing what kinds of sexual behaviors they would seek and what kinds of sexual behaviors they would engage in, right? And we would also do a lot of key informant interviews in the community to determine who was at the greatest risk for acquiring or transmitting HIV. So we had this pretty good idea that these individuals that claim to be sexually inactive were in fact highly sexually active. But why wouldn't they want to disclose this to us? Their reluctance to talk about sex was directly related to stigma. So they felt that as prevention workers that we would judge them for having sex. We would tell them to stop, or we would try to push condoms on them when they didn't feel like they wanted to use them. And these may have been things that they've experienced in the past by other providers, right? It may be something that they just assume would happen based on subjective norms and that internal stigma. But the point is that the lack of honest conversations could really have hindered their quality of care. And we needed to do our best to support those open and honest conversations, free from judgment, so that we could provide them with a full range of options based on their specific needs. Other examples, persons living with HIV might be afraid to disclose their status to their sexual partners because they're afraid of rejection. They might be afraid of someone violating their confidentiality and telling other people their status. They might be afraid of the possibility of even criminal prosecution, depending on where you are in the country. And individuals might not want other people to know that they're living with HIV, and therefore they don't want to go to their care clinics because they don't want people to see them walking into a clinic that treats people living with HIV or AIDS. They could be they could be afraid to disclose their status to healthcare providers because they're afraid of being judged, or because of the same reasons they're afraid to access prevention services, right? That their healthcare providers are going to ask them all these questions, tell them to stop having sex, push condoms on them, and things like that. There are lots of different reasons that stigma can affect health outcomes. And as providers working with this population, we really have to do our best to show our clients that we're not going to stigmatize them for living with HIV or for the behaviors that they are engaging in.